right. We'll
Yeah.
start and more people will probably come in. So welcome everyone from all over the world. It's great to have you all joining us this evening. Before we get started, I'll just introduce some of the Zoom webinar features. So first of all of this, just the speakers, you can see our video and audio, but as an attendee, you are muted and you can't see your video, so you don't have to worry about your own camera or anything like that. If you want to introduce yourselves, please use the chat at the bottom, and just a reminder to select to all panelists and attendees if you want everyone to see it, instead of just to the panelists. If you would like to ask any questions, use the Q&A function at the bottom, and you can also go on there and upvote any questions that you see that you're interested in answering, and that way we'll answer those all at the end with Jonathan when he's finished his presentation. And just a reminder to follow us on Twitter, so we're at CIMTR_ARU, and to use the hashtag CIMTR Webinar. So welcome to our webinar this evening. We're hosting this from the Cambridge Institute for Music Therapy Research. And I'm just going to hand over to Professor Helen O'Dell-Miller, who is the director of the Research Institute.
Hi everybody and welcome, and thank you so much. That was Jodie Blosker, without whom you would not all be here able to witness the public lecture. So thank you, Jodie, who is a research fellow in the Cambridge Institute for Music Therapy Research. For those that don't know, Cambridge Institute for Music Therapy Research is at Anglia Ruskin University in Cambridge in the UK, and we're an established research centre where we specialise in looking at music therapy research and clinical work for people who live with mental health problems, both children, families, and also we particularly have researchers led by Professor Jörg Fachner and his team looking at music therapy and neuro rehabilitation and brain interface, really looking at new research that's happening, for example, looking at synchrony within music therapy sessions and through EEG measures and music therapy. We have a group of researchers. You can find out from our website more about the research. Also, we have work going on in the field of stroke, Dr. Alex Street's work, and a large focus upon music therapy for people with dementia. And we've got two quite big, fully funded studies at the moment, one funded by the EPSRC and another one funded by Alzheimer's UK, which are looking at ways of working with people with dementia and their carers and their families, particularly looking at home-based work. One of them is called Radio Me and the other is called Homeside. There's so much more we could say. We have just had a day of working with our PhD students. We've got about 19 here based in the unit, and we've had a virtual seminar today with some brilliant presentations, and this is the culmination of the day. This is part of our public lecture series that we've been running for nearly 3 years, and normally they happen in person on a Monday night in Cambridge, and we usually have an audience of about 30 or 40, and having moved in the COVID situation to running these online, we're very pleased to welcome you all, and we're expecting over 200 people today. So we're now thinking about developing our virtual online series so that people can access the research. So I have great pleasure in introducing Dr. Jonathan Poole. Jonathan now works partly at Anglia Ruskin University 2 days a week on our Homeside project. And you've just seen his PowerPoint with the title of his lecture. He's a music therapist, clinical supervisor and researcher, specialising in neuro rehabilitation. And at Anglia Ruskin University, he's been a senior research fellow here since last May. He's also a senior arts therapist working for Chroma, and he's just been welcomed as research chair for the Independent Neurological Providers Alliance. And he works for the Children's Trust, the work of which he's going to speak about that happens there with children. So without further ado, I'd like to welcome Dr. Jonathan Poole. Over to you, Jonathan.
Thank you, Helen. I'm just getting this set up here. Can you see that? Yeah.
Yes.
Right, there we go. Okay, so well, many thanks to Helen and to Jodie for making this possible. This is a great opportunity, so I'm very lucky to do this. Okay, so this talk is going to be about music for the assessment and treatment of children with disorders of consciousness. I will refer to music in neurological development and how music can be used after a child has disorder of consciousness. Unfortunately, I don't have any videos of any clinical work, and that's mainly because it's very difficult to get permission to use videos of children with disorders of consciousness, in my experience anyway. I know they do exist, but I've had difficulty using them in public lectures. Rather than keeping this very dry and referring to research, I thought I would use a hypothetical case as a way of providing some context for the research in this talk. Okay, so this is made up, but it's sort of bits of different people that I've worked with over the years. Okay, so hopefully by the end of this presentation, you will have heard some of the arguments for using music with children and young people with disorders of consciousness. I would like to share some information about some of my research, which is about the Musica, which is an assessment tool for working with children and young people with disorders of consciousness. And I'm hopefully going to describe how music can be used with this population to assess awareness and address sensory problems. Okay, so let's begin with the fetus in utero. And we'll begin with our story. So this fetus is meant to be the son of Mark and Rachel, and we're going to call him William. This is their first child, and they had been trying to have a baby for some time before Rachel finally became pregnant. The pregnancy has so far been uncomplicated with no unexpected issues. Mark and Rachel have been preparing for the birth by attending prenatal classes and getting the home ready, as many of us do. They are both music lovers and have music playing every day at different times of the day. Now, while in utero, the fetus's auditory system is developing. So please excuse the fact that this is not a representation of a child's brain. It's very difficult to find a representation of a child's brain with what I need on there, which is basically the inner ears and the links to the brainstem and the auditory cortex. So the development of the auditory nerve. So let's take a look at this process of the developing auditory system in utero. The earliest evidence of auditory evoked response is at 16 weeks gestational age, which I think is quite amazing, really. So at this age, the ganglion cells in the cochlea, which is here, there's the cochlea, the ganglion cells in there, which connect the hairs in the ear, they connected to nuclei in the brainstem. My pointer keeps disappearing. So in the brainstem here, okay? Now, that's important because this stimulates a physiological response to a sound or to an auditory stimulation. So the brainstem is responsible for automatic responses So they're not mediated by the cortex. There's nothing considered in the process. They're automatic. At 25 to 26 weeks gestation, a loud noise in utero will produce changes in autonomic function. This can cause changes in heart rate, blood pressure, respiratory pattern, gastrointestinal motility, and oxygenation. So the connections, further connections are made between the cochlea and the brainstem and the temporal lobe. Then between 28 to 30 weeks gestation, connections to the temporal lobe of the cortex become functional. So the wiring is created first, and then it starts to work. The neural connections to the temporal lobe of the cortex are functional around this time. This enables preparation of the cortex to receive, recognize, and react to language, music, and meaningful environmental sounds. When the auditory system becomes functional, the brain can then be modified by environmental stimuli. So this is plasticity. Now, let's return back to Mark and Rachel and their baby. So Mark and Rachel were very excited parents and wanted to know more about their baby. This is their first baby, so they didn't know much at all. They had bought some books about parenting, and one of the books suggested playing music, singing, and talking to the fetus in utero. They were fairly open-minded people and decided to try it out. They noticed that their baby moved when they spoke. So their baby, William, appeared to be responding to the sound of their voices. Now, real-time ultrasonography makes it possible to observe the responses of human fetuses to sound. And two people called Shahidullah and Hepper in 1994 presented pure tones and spoken syllables to fetuses at 27 and 35 weeks post-menstrual age. Each fetus was presented the same sound until it became habituated, so it became used to it. And the behavior that they took to mean that habituation had occurred was that there was no further movement, so no motor response. A different sound was then presented. If the fetus responded, this was interpreted as evidence that the fetus could discriminate between the two sounds. All the fetuses habituated to the first sound, with more stimulus presentations necessary for habituation at 27 weeks compared with 35. The fetuses at 35 weeks responded to the dishabituating stimulus. So this experiment showed that fetuses can discriminate between two sounds around 35 weeks post-menstrual age. These observations also suggest that fetuses at 35 weeks show signs of simple learning and short-term memory capabilities, as well as frequency discrimination, because they have to remember the sound in order to be able to respond to it or not. So this suggests that some familiarity to sounds develops in utero and continues to develop after birth. To do this, the infant must possess the apparatus to distinguish one sound from another. This involves sensitivity to pitch, intensity, and timbre, and suggests that infants have templates stored in their memories of salient auditory stimuli, for example, the mother's voice. Now, a researcher called Webb et al., or a group of researchers, played authentic recordings of the mother's voices to preterm newborns. So newborn babies born before the term is finished. The study provides evidence for experience-dependent plasticity in the auditory cortex in preterm newborns exposed to authentic recordings of maternal sounds before full-term brain maturation. So what they noticed was that in the babies that they played they played the authentic maternal recordings to, that there was an increase in the thickness of the auditory cortex. So this is evidence of plasticity due to environmental stimuli in very young human beings. It's also worth noting that a researcher called Machado in 2007 documented a few cases of children with disorders of consciousness responding more effectively to their mother's voices than to any other voices. Okay, so back to William. As William progresses through his preschool years and begins school, he learns new words and songs. He experiences emotional responses to songs and music. He develops preferences for specific songs he hears. His brain is responding to auditory patterns that appear salient and familiar, and stores these patterns for retrieval later. His brain does this automatically. He doesn't have to try to do that. When he listens to music that he likes, his brain experiences recruitment of multiple regions bilaterally across both hemispheres, including cognitive and also the regions of the brain involved in emotional processing, which are key to laying down memories. Blood flow around his brain increases with this increase in brain activity, and his heart rate variability also increases. At moments of peak enjoyment, his brain releases dopamine, which stimulates his attention and memory processes. Now, much of the research that is in front of you in those statements are based on work with adults. So but I don't think it's too much of a stretch to say that this would happen with children as well. Although I don't know of any studies to do with children that measure the same, these same processes that we have in adults, but they're fairly fundamental. Okay. So just to recap, the brain is capable of processing auditory stimulation before birth. The brain can undergo changes as a result of auditory stimulation in early childhood. And salience and familiarity appear to be developing very early. So that response to salience and familiarity is important from an early age. It's not just something that we need as adults. So then at 8 years old, William is involved in a road traffic accident, causing him to sustain a severe brain injury. This resulted in William being left with a disorder of consciousness. William was taken to an accident and emergency unit where his health status was stabilised, and following a few weeks on an acute ward, he was moved to a post-acute setting. Now, I also work at the Children's Trust, as Helen has mentioned, and that would be described as a post-acute inpatient setting, where we receive different kinds of children and young people at different stages. But some of them do have a disorder of consciousness when they arrive. So it's a National Specialist Centre, and families do also have accommodation there and come to stay, so they can be with their children throughout the day. And they come with a lot of expectations and preconceptions about what they hope will happen as a result of staying at the Children's Trust. So the Children's Trust is positioned between the hospital and the community, and so it holds the hopes and expectations of the family, while also preparing them for returning back to the community or back home or to a new home. Changed by itself. Right. So let's just have a look at the medical model of consciousness. So rather than a philosophical model. So from the Royal College of Physicians, consciousness is an ambiguous term encompassing both wakefulness and awareness. So we already know that it is difficult to describe and difficult to pin down. So assessing it's a bit of a challenge. But we have these two facets: wakefulness or arousal, which is a state in which the eyes are open and there's a degree of motor arousal. We also have the other facet, which is awareness, which is the ability to have and having of experience of any kind. It's being aware of that experience, being able to do what the brain does really well, and that's that it relates the self to the environment and the self to the body. There is no single clinical sign or laboratory test of awareness. Its presence must be deduced from a range of behaviours which indicate that an individual can perceive the self and the surroundings, frame intentions, and interact with others. So it's, in a lot of ways, a functionally based behavioural assessment is what we would be looking at. Just to give you an idea of the different types of disorders of consciousness, you have in the far left column coma, which for each of these sort of pillars, you have arousal on the left and awareness on the right hand side of it. Now the pointer on the left indicates that there is no arousal, so there's no eye opening, there's no response to any of the stimuli. And as a result, there is no awareness either. So no interaction with the environment or to formulate intentions and communicate. In terms of the next, I suppose, level of awareness or level of consciousness, which is called the vegetative state, which is a term that people find uncomfortable to use. There have been various attempts to alter that, and currently the term unresponsive wakefulness syndrome is often used, although there isn't widespread acceptance of this yet. But this state is characterized by the presence of wakefulness. So there may be a sleep-wake cycle, but there is no evidence of awareness. So in this state, we might find that there are reflexive movements, so the brainstem is active, but we won't find evidence of cortical activity, so control of responses. In the minimally conscious state, there will definitely be evidence of wakefulness and arousal. However, the ability for the person to be able to interact with their environment will fluctuate over time, and some will appear momentary often. So there might be very clear responses that we might see occasionally, but not consistently. Locked-in syndrome is not really a disorder of consciousness. It's on this slide because it's included in the original picture. But that's more of a motor disorder, really. Okay. So William has ended up in the Children's Trust because of a car accident, and he's unable to communicate with people in his environment. So the problem is that the people caring for William need to know with as much certainty as possible how aware William is of his environment and of his own body. They need to know if he perceives pain, and if he is in pain, where he is in pain. They need to know how sensitive he is to touch, to light, to sound. Does he even know that he has a brain injury and that he's in hospital? They need to know how conscious he is, because if they do not, he may not receive the right amount of stimulation. He may not get access to services if they do not believe that he will be able to access them either. And there may be other legal decisions that need to be made, which are dependent on what people believe he can get access to. In the latest guidelines, which have come out this year from the Royal College of Physicians, I think they suggest that the difference between the vegetative state and memory conscious state is more important for legal reasons rather than for in terms of planning treatments and things. But I'm not sure I quite agree with that. Okay, so why is it important to have an accurate diagnosis? Well, end-of-life decisions depend on it. We also need an accurate assessment of the current responses to be able to determine how aware somebody is of their environment and their surroundings and what they can access. We need to be able to provide them with optimum stimulation. So for some people who have a severe brain injury, they might have developed sensitivities to stimuli in a particular modality. And we would need to know that so that we can manage the environment around them to provide them with the optimum stimulation so that they don't become bombarded by stimuli, and also so that they don't also suffer from sensory deprivation. It also provides us with accurate planning for future needs regarding when someone goes home, what kind of team they're going to have, and for children, when they go to a school, what kind of school they go to and what facilities they're provided with. Okay, so the assessor's goal, in this case, a music therapist's goal, in the assessment and treatment for this client group is to raise and maintain the patient's arousal to an optimum level to give him or her the best chance of responding. It's to help them. So assessment always with this client group is not about catching them out. It's about giving them the best chance of showing a positive response. So a little while ago, Professor Wendy McGee and colleagues developed a tool at the Royal Hospital for Neurodisability called the Music Therapy Assessment Tool for Awareness in Disorders of Consciousness, or MATADOC. It was developed from 1990 to 2004, over a significant period of time, and was refined for a further 4 years. The original title was Wakeless, which I think is the music therapy assessment tool for low awareness states, I believe. The protocol includes behavioral observation. So you have this systematic protocol, which is quite experiment. It's not experimental in the sense that you're using a control, but you're controlling the stimulation that you're providing, and that is combined with a detailed behavioral observation using rating scales. Research has been carried out with the MATADOC since 2008, and it was developed out of clinical work which has been carried out at the Royal Hospital for Neurodisability. It is a validated tool, which means it can be trusted to be used with adults, and it often contributes to the comprehensive assessment around a person with disorders of consciousness. Okay. So the purpose of the MATADOC is to contribute to the multidisciplinary assessment to get as much information as possible. It's widely agreed that not one assessment is enough. Usually multiple assessments are required within clinical teams. It's also to provide a baseline of the responses prior to rehabilitation so that we can show any change if the change has occurred, and to gain a detailed picture of someone's sensory responses. Okay, let's move on. So some of the characteristics of the MATADOC are that it utilizes visual, auditory arousal, wakefulness, and verbal items, amongst others, including vocalization and affective responses to look at how aware somebody is of their environment. The MATADOC is able to provide a detailed assessment of auditory responsiveness. People say it's finely tuned for auditory responses. And interestingly, it's one of the few assessment tools which utilizes familiar salient stimuli in the protocol. Just a note about salience and familiarity. So music can be particularly salient as a stimulus depending on the patient's exposure to music. So the more that we listen to music and enjoy it, the more sensitive we might be to that as we become used to it. The factors of saliency and familiarity position music as an ideal stimulus for attaining optimum arousal and eliciting awareness in children and youth with disordered consciousness. Recent guidelines advise that evaluative stimulation used with patients with disordered consciousness should maximize stimuli that are familiar to the patient, highlighting the use of the patient's favorite music. And that was from the Royal College of Physicians. One study by O'Kelly et al., comparing auditory conditions with varying levels of saliency, showed that music with known saliency improved arousal and attention in vegetative state patients, and revealed indications of improved discriminative attention in minimally conscious patients. This study examined physiological and electroencephalography responses in patient and healthy cohorts during 5 auditory conditions. And that was silence, patient preferred salient music, improvised music, and trained on the subject's breathing. Patient disliked music and white noise. So that's saliency. Now, familiarity is also important. Eilander et al. In 2011 compared the effects of musical preference with familiarity and found that familiar music triggered greater emotion-related brain activity than music that was liked but not necessarily familiar. So they showed that even though liked music induced more greater emotion-related brain activity than disliked music, familiarity had a greater effect than liking music. So, back to William. There's no validated tool for determining what level of consciousness William's at and providing a sensory assessment. So the clinicians decided that they would adapt a measure. Now, the problem with doing that is you end up with multiple homegrown measures, none of which are validated. There's also, because each group would be doing their own thing, they might be taking different advice or no advice on what changes to make. So there's no consensus on what is a valid change and what isn't. So this would lead to unstandardized, unvalidated measures in use. So the question would be for the clinicians, how much can we trust these assessments for William? And how do we then communicate that to his parents? So the MATADOC, which is validated for use of adults, has been used in a study with children, and a pilot was carried out in 2015. We also decided, as part of developing the Musica, we decided that we would ask a group of trained assessors with experience of working with children and young people to see what they thought about the MATADOC and whether it needed adaptation and what adaptation would look like. So from the pilot and from that feedback, we gathered some ideas really. One was that the verbal elements needed revision to account for changes in language due to development in children. We also needed to find a way of involving the family because we found that everybody had difficulty knowing how to do so, and that also that everybody noticed that the family wanted to be in the room and wanted to be involved. We wondered about what the minimum age for a measure that looked at consciousness or awareness would would need to be. We wanted to find out whether we could use touch and vibration, especially given the fact that the skin is an organ which completely covers the body and has lots of nerve endings, so it might be useful to use that. And also, many of the clinicians wondered whether it was possible to use the Matadoc with fewer contact sessions, because currently it's used, you need to have 4 contact sessions to be able to carry out the assessment fully. And that might pose certain problems in an acute setting. Now, also interestingly, in 2019, Alvarez, Saskawa and Slomi looked at the clinical features of disorders of consciousness in young children. And they found some very interesting results from their work. They used a modified version of the Coma Recovery Scale revised to operationalize behaviors consistent with VS, MCS, that's vegetative state, within the conscious state, and CS would be conscious state. So this would allow them to describe which behavioral indicators you'd assign to the different states of awareness or the different disorders of consciousness. Now, what they found through their method and their analysis was that the visual and motor skills appeared to be the most applicable in being able to determine differences. So they didn't find that the auditory domain was particularly useful in determining differences between vegetative state and luminary conscious state. And they also found, like many of us were wondering at the time, was that language-based skills were the least applicable for younger children. So language needed to be dealt with within the assessment itself. So a heavily language-based assessment is quite difficult to use with very young children. Now, the cohort that they studied was 54 children with an average age of 2.7 years, with the youngest being just over 6 months old, and the oldest being about 5 years, 10 months or something like that. Okay. Now, one of the main, the key messages from that research was that they highlighted a need for developmentally appropriate classification of disorders of consciousness. So we couldn't rely on adult measures. Interestingly, Gilthwaite and Monday found that the auditory modality is indicated as the most sensitive one for diagnosis in disorders of consciousness. So that's I've provided that for a bit of balance really between the two opinions around the auditory domain. Okay, so I've been involved at the Children's Trust in developing something called the Musica, and that's the music therapy sensory instrument for cognition, consciousness, and awareness. This is based heavily on the Matadoc, and I've been developing this with Professor Wendy McGee. And so we have been making adaptations to Matadoc in order to make the Musica, so this pediatric version. Now, it contains, what you have there is a protocol which contains 7 steps, which is the introduction of the musical stimulus. For most music therapists, you call that a hello song, but it's a very specific presentation of music. So it's not just any hello song. There's a specific way that we present that in terms of thinking about the breathing of the patient and also about the level of stimulation we're providing. Everything is very carefully thought about before providing. Step 2 is the presentation of the visual stimuli, and then we go through the presentation of others, including auditory stimuli and vibrotactile. So vibrotactile for, in terms of music, would be music that's a musical instrument that might have a stronger vibration, and then we might hold that near or on the skin of the young person. There's still a presentation of double command in there. And also the presentation of salient familiar musical stimuli. So familiar songs for that individual. Now there's two levels to that. Second level refers to whether we see evidence of any sort of response to that music. So that might provide us with a moment to develop that further and enter into a dialogue. So that was the protocol. Now within the Musica, we have 15 items which we rate in order to arrive at a comprehensive assessment of sensory responsiveness. And the ones in the green box are the ones that we use which we use to provide the diagnosis. So those are the ones that are key. We've eliminated the other ones because of issues around choice making and response to verbal commands that we're likely to see with young children particularly. Okay, so the differences between the Matadoc and the Musica are the attention to language and tones of voice used in the assessments have changed. So one of the things that we wanted to be able to do was we had to simplify the language, but also one of the techniques that we used at the Children's Trust was to find out a bit more from the parents about how they spoke to their child. So some people speak quite softly, some people are a bit louder, and we noticed that some parents spoke not in an authoritative way, but in a very motivational way to their son or daughter, and that seemed to have an effect. So it's about replicating that. Really. We included the family member in the protocol, so there are guidelines for how to include a family member. Then, rather than using the Matadoc's method of conditional calculation or computation for diagnosis, we have agreed to use the best response recorded, which is similar to the way the coma recovery scale arrives at an indicated diagnosis. We reprioritised the items in the principal subscale, and we included the vibratactile item. So this is just an example of one of the items on the rating form, and this is the response to musical stimuli. So this would be the initial hello song, or some of the familiar salient musical stimuli that we might present later. So what we have here, so the area in red would indicate a response similar to someone in a vegetative state, or an unresponsive wakefulness state. And that would be if there's no response at all to the music, or if there's some activity that's unrelated to musical stimuli. So the activity wouldn't start or stop when the music starts or stops, or there's something that's happening, but it can't be connected to what has just been presented, because it could also be going on continuously anyway. The yellow box indicates responses that we would expect to see with somebody in a minimally conscious state. So that there are responses which are consistent with or contingent with what has just happened in music, but that they are inconsistent in that they don't happen reliably enough, essentially. So we'd be looking at sort of 3 out of 4 times. And the next level up from that would be we have the rating 3, which is responded for the duration of the music only, so that there's a contingent response, and it happens when the music's playing, and when the music stops, the response, the behaviour stops. So it could be eye-opening, or it could be head turning, or something like that towards the music. And in the green area, you have the 2 responses that we would expect to see for someone who's emerging from a minimally conscious state and becoming more conscious. So those would be around inconsistent interactive responses. So that could be turn taking, or it could be use of voice within a musical exchange, and then of course consistent interactive responses within that. Okay, we're aware of the time. I'm not sure how many minutes I have left, if any. I'll carry on until you tell me to stop.
Maybe a few more minutes, Jonathan, and then we can take some questions.
Okay, that's fine. I'm nearly finished. Thank you. So some of the outputs from the Musica are that we wanted to capitalize on the use of computers and using graphical representations of these assessments, because they're quite detailed assessments, so they can be very wordy. So we decided that we would provide a radial plot, which is some people call them a splat, and it was to provide a sort of a profile of the person's abilities, so regarding their strengths and their developing areas, and also thinking about skills that may not have been shown. And this informs goal setting, which allows educators and other members of the team, therapists, etc., to know what you've seen and what they might be able to provide as well. Because if you've seen that actually you've noticed that particular instrument is useful, because you have the opportunity to explore that, then they would indicate to them to maybe include that in one of their sessions. So just briefly looking at the validation study that we're involved in at the moment. So we've developed the Musica, and we're quite happy with it. It's taken a while, quite a few years. We developed it in collaboration with other professionals from other disciplines, and also with some colleagues from around the world who are trained assessors, and also by speaking to families. So this study that we're currently in the throes of at the moment, we're in the early stages, is a validation study. So we can look at the validity, the reliability, and the clinical utility of the Musica.
Yeah.
The initial stage is looking at face validity. We need a sample of 20 for that. After we then move to recruitment at multiple sites in the UK, Ireland, and the United States, we will then conduct the comparison of the Musica against 3 other tools to see whether how it performs and whether there's agreement. And then we will also test to see whether it performs the same way with different assessors. So that's inter-rater reliability, and also whether it performs the same way each time it's used. Okay.
Great.
Yeah. So ethical approval has been granted, and at the moment we are in the stage of evaluation of face validity, and it's nearly complete. Thank you.
Oh, thank you so much, Jonathan.
Thank you.
Thank you very much, which leads into our question and answer time, and people are getting very active now on the facility. In fact, one of the questions was, is this tool validated yet? So I think that's just been answered by the last slide. I'll hand over to Jodie for the next. Well, we've got one which is from Alison Sweeney. Is there information on how familiar music is presented in the Pereira et al. Study from 2011 that you mentioned? For example, does that study look at pre-recorded original works by artists or music therapists' renditions of music preferred by the child? So we could kick off with that one, Jonathan.
Okay, if I remember well enough, and I'll have to check, I mean, I can always take Alison's email and sort of point her in that direction. But as I recall, it's not a music therapy study, it's a music psychology study, and they used pre-recorded music, so there's no live music presented. Some of it, I think some of it was, they had to firstly identify familiar music and then find music that was presumably unfamiliar. And of the familiar music, I think the subjects needed to identify music that the songs that they liked, or pieces of music that they liked, and pieces of music that they disliked. So that's a process at the beginning of the study where they were looking through, listening to pieces of music and identifying ones that they knew and didn't know.
Okay, so they're probably pre-recorded, not
all pre-recorded music.
Live in the mix. Okay, that's great. So I'm going to hand over. Jodie and I will probably do this together. So Jodie has probably now got a question ready.
Yes, so we have one here from Jeff. I would love to hear a little bit more about how the family are involved in the Musica protocol and how or whether that can influence the result.
Right, good question, thank you. So because families, well, you can't generalize, firstly, and each family has a different response to being in this well, terrible situation, really. Often, though, I found that they do want to be in the room, but then aren't quite sure what to do. And one of the difficulties when doing an assessment of this type is that we need to be sure that the response that we see is as a result of what we've done. And the reason for that is then we can then assign that response to that stimulus. If something else happens, so the environment's not controlled, for example, a parent or a sibling speaks or encourages with a kind of really encouraging word or sentence or something like that, and then the person with a disorder of consciousness responds, but we then don't know how whether it's as a result of what we've done or what the family have done. So the way that the family are involved is that we have we'll invite them to be involved first of all, and check to see whether they're comfortable to be involved, because actually it could be difficult for them too. And then we can explain to them what it is that we are intending to do and how we're going to go about doing it. So they have an understanding of what they're going to experience themselves in terms of what they're going to see us do and hear us do, and how they would be involved in the session in that way. And that will be often by providing verbal command when it's or verbal instruction, if they feel comfortable to do so. It could be often. It could also be if they feel comfortable enough to sing as well in the session. But some parents may not feel that comfortable about doing that. There are times when actually it's just not appropriate for them to do anything. So they would be, because we're providing just a very, very discrete stimulus, and so that at that point it's important for them to remain out of view and not to sort of make a sound for a bit. It can be quite uncomfortable to do these assessments because they are at each end, so they're bookended by about 3 minutes of non-stimulated observation, which is really important. And we have to sort of explain why we're doing that, because it can feel quite uncomfortable to sit in a room for 3 minutes and just observe somebody. Yeah, I hope that answers the question.
Jonathan, thank you. Actually, you've also answered, you've gone some way to speaking about another theme that's coming up, which is about the voice of the mother used as a stimuli and also the parents. So I think maybe we've covered that because we've only got 5 minutes left now. There's another theme which is going on in the discussion, which is about a minimum and a maximum age for this.
Right. So we're in the validation study is we're looking at 2 years to 17, really. So the minimum age, there isn't a maximum age, to be quite honest, because it's all about what the stimuli you present, because they're salient and they're familiar. They will be specific to the individual at whatever they were doing before it happens to them. In terms of a minimum age, we took 2 years as the minimum because we weren't confident that going below 2 years was really fair. And one of the issues with acquired brain injury with very young children is that often they can be diagnosed as having cerebral palsy rather than acquired brain injury when they're so young. And also, we looked at some research to do with theory of mind, and suggested in the research that around 18 months is plus or minus about 3 months is around the age at which theory of mind seems to develop. So we thought that might be important as we're thinking about awareness as well. So.
Thanks very much. Jodie, I'll hand over to you.
Yes. On that theme, actually, there's a question just asking about if someone's, say, teenage, if there's no maximum age, which what might you choose, the Matadoc over the Musica, or vice versa?
A teenager. So, well, I suppose it depends on. I mean, teenagers are a very varied group. Really, I suppose it sounded like we made a lot of changes to the Matadoc. We actually really didn't. There's not a lot of difference between there are some significant changes. I mean, it's not the Matadoc, but it's it's very similar. So I think probably that if somebody is looking for an assessment tool that is going to be useful for a teenager, and if we were talking a sort of 15 or 16-year-old where their language development was typical beforehand, because that's one of the key issues, then I would say that the Matadoc would probably be okay, even though it's not validated yet for I don't think so. Wendy McGee will probably be able to give us the most up-to-date information on that, actually. But I would say that would be okay in the absence of being able to use anything else.
Yeah.
But with a provider that actually, the person using it needs to remember that that they're using something which is adapted.
And so, Jonathan, we've got a couple of minutes left, and there's another theme which is about training. The theme is about the two different questions. One is, can existing qualified Matadoc assessors undertake this, or will they require additional training to use the Musica? And the second part of that is, do you have to be a music therapist to do the Musica training?
So
and other professionals learn to do the Musica assessment?
Yeah. So, so the first part of that question is about whether trained assessors would be able to use the Musica or would need to have extra training. So what we are going to do is, rather than create another training, because actually all these skills are there, is that there will be probably some sort of online training that we could do, which would be fairly short, just to be able to go over the elicit and probably some, I would think, some assessment of competence, just to make sure that the assessor is using the instrument in the correct way, in the way that we've designed it. But yeah, it shouldn't involve a 3-day training or anything like that, because the Matadoc training is comprehensive. So it's only an adjustment to that. Oh, and the other part of that question was to do with...
do you have to be a music therapist to do the training? Well, that was, or can other professionals undertake?
Yeah, so other assessment tools allow other professions, multiple professions, to be able to do it. But the Matadoc and the Musica are for music therapists. They're both music therapy assessment tools. And because of the use of improvisation and the sensitivity with which I think we should be able to expect all music therapists to be able to listen in the way that we are trained. Because of that sensitivity, the observational skills and the use of improvisation within both the Matadoc and the Musica, I think it's important that it's a music therapist undertaking it. So unfortunately, we can't make it available to others, but that doesn't mean that in the future we won't be able to do that. But we'd have to think about how we would open it up to others, really.
Yeah. Okay. Thank you, Jonathan. On the chat, there are some incredible thanks there from participants to you, and also, been some great questions. A wonderful presentation, Dr. Poole. Thank you very much. A very interesting presentation. So I just thought I would, read some of those out as I go. We're due to finish now, but we could stay on for another few minutes. People could leave. If you need to leave, that's the official end, but we can stay online, and Jodie may have one or two more questions for you, Jonathan, if that's okay.
Fine. That's absolutely fine.
Yeah.
Thank you to everybody who
Yes.
made the effort to turn up. It's,
Sure.
Thank you very much.
And we'll just carry on for another 5 minutes, maybe. So Jodie, back to you.
Perfect. So we have another question here from Joanne. Could this be used in other settings such as pediatric intensive care where consciousness might be altered by drugs rather than injury?
That's very interesting. So pediatric intensive care. Well, one of the reasons why we were interested in finding out whether we can use a tool like this in fewer sessions, fewer contact sessions, and that's part of the study that we're doing at the moment, is to compare 1 with 4 sessions and 2 with 4 sessions and 3 with 4 sessions to find out whether it works consistently well. So it hopefully would be able to be used in something like an intensive care unit to be able to help find out a bit more about someone's sensory responses. So one of the important things with children is that their nervous system, when it's damaged, it's different to when an adult his nervous system is damaged. And one of the things that certainly I've noticed working with children with disorders of consciousness is the impact of sudden sounds or sudden impulses, even touch or light, and how they can produce seizures and due to startles and things like that. So I would imagine in an intensive care unit where thinking about this would be quite helpful in terms of managing the environment, if it's still possible. I would think that it could be used there. It would be. I would like it to be. Yeah.
Yeah, great, thank you. And another question here, I'm just thinking about design and taking the research further. There's a comment about whether you might consider undertaking the assessment twice, once with parents and family there and once without, and sort of likening that to medical practice, that doctors might use that type of test in this type of environment with this population.
That could be very interesting. I hadn't thought of that, actually. I think it would be, yes, it could be interesting to find out the effect of the family in the room, to see whether actually they're providing so much more stimulation, in fact, than we might recommend that the family must attend. Although that in itself might be problematic because of the loss that the family might be feeling at the time, and because the family are going through not just the child being in hospital, but the potential for everything changing in their lives forever, and they're dealing with that. So yeah, I think it'll be interesting, but I think I'd be careful about what the implications might be of that sort of study.
Yeah, ethically. Jodie, so I hand back to you. Maybe we could have one final question.
Yes, so there's one more from Richard. Has 4 votes, so we'll go with that one. What sort of things do the verbal elements of Matatalk / verbal commands of Musica involve?
So the verbal command is very much like the Matatalk, except that the language would be different. And it involves identifying a behaviour, first of all, usually in one of the other stages in the protocol. And so it's something that the person can do, but they don't do automatically, okay? So it's not a reflexive response. And then instructing them to do it. So it could be, if you've noticed a limb movement that seemed meaningful. So, for example, I'm a guitar player, so let's imagine that I'm with William and take the guitar to him, and I play close, because I'm looking at proximity as well to see whether that has an effect. And his left arm raises as I'm on his left side, and it made me wonder whether he was reaching for the guitar. So that only happened at that moment. Now, if I then think, well, for a verbal command, I could say, raise your hand, or lift your hand, or move your finger, or something that I've noticed him do. And that's what it would be. That's what it would be. It could be that I hold the guitar nearby and I say, touch the guitar. Those are the sorts of things that we'd be thinking about doing.
Thank you, Jonathan. There's so much more. I think we could go on for a long time having this discussion, and people will know how to contact you. There's Jonathan's email addresses up there on that slide. I'd like to thank you so much for that wonderful presentation, and it's so informative and taking us right through the developmental process for someone in this population, and for this groundbreaking work developing the Musica, which we're really excited about having involvement here with you on that at Anglia Ruskin University. And thanks so much. Thank you to Jodie and anyone else who's been involved in making this happen. And we run a regular series, but we don't yet have our final programme for the next academic year. This is the final talk for the moment. That's right, isn't it, Jodie?
Yeah.
Yes, correct me if I'm wrong. Did you want to add anything, Jodie, to people? I think we're just compiling next year's.
Yeah. So after you sign out of the webinar, Zoom should direct you to our evaluation survey. And on there, you can let us know if there's any speakers that you'd like to hear from next year for our next year's webinars and public lectures. So hopefully we'll continue doing some online, which would be great. And we might have to anyways. And yeah, just let us know who you'd like to hear from. And you can also sign up to our newsletter, and in the email that you'll get as a follow-up email, there'll be a link to that to subscribe to that to hear about our future events.
Thank you. So I think we have to leave now, and it's very it's quite frustrating not being able to speak to you personally. I can see so many names there of colleagues, alumni from Anglia Ruskin, colleagues from all over the world, and new visitors that we hope you'll come back again to our series. So it's goodbye from all of us at CIMTR. Thank you again, Jonathan, and keep in touch with us. We have a newsletter and database and things that you can be part of, and we hope we'll see you again. Okay, bye.
Thank you.
Thank you, Jonathan.
Thank you.
Thank you, Jodie and Helen. And thank you to all of you.